Thank you, Dr. P, for taking the time to, come out and talk about GI. I'm interested in GI personally too, so, I wanted to kind of grill you a little bit and get the insights of GI.
No worries. Thank you for allowing me to participate. Of course, for those who know me, and who have heard me talk before, I'm pretty excited about the field of gastroenterology. Today, I put some basic information. Hopefully, the interest will also be stimulated in those who are looking. But especially depending on where you are in the stage of your medical journey, whether you be a first year medical student or maybe already a fourth year medical student or also going through residency, thinking of specializing, there are some things that I think the slides will kind of either give you a review or give you some anticipation of what to expect if you're going to pursue the field of gastroenterology. I may also throw some personal comments, along my journey, but as much as possible, I'll try and give you the basics that is shown on the slides here. So, of course, being a doctor, a GI doctor is the best, and peace, love, gastroenterology, butts, guts, and glory. And there's a whole bunch of GI jokes and comedy things related to GI, which you'll probably hear. Some humorous, some kind of straightforward, but all in good humor. So go ahead. And going with that humor, um, I will tell you, being a gastroenterologist and actually having family, two kids, and since my wife's also a healthcare professional, she's a nurse, there's no shortage of topics that you can't that are off limits at the table. So I'll talk about nausea, vomiting, colonoscopies, patients. My wife will even bring things up. Patients threw up on her or during the day. And it's like, what do you think it is? I'm like, I don't know. So our kids are very much aware of things. Fiber is also a common thing that you hear GI doctors say, drink more hydration and also eat more fiber, which is obviously good and healthy, generally speaking, but there's humor always associated with that. So you're eating too much fiber. The field of gastroenterology. So gastroenterology, often gastrointestinal and liver diseases. It's a medical, non-surgical specialty that focusing on the digestive diseases. Of course, the organs involved, stomach, intestine, pancreas, liver, colon, etc. These are all involved. We're known as GI doctors, but we actually treat a whole bunch of different diagnoses. And what you see on the screen here is just a small sampling of what people will go to a gastroenterologist for. So heartburn, IBS, IBD, which is totally different, but sometimes the acronym IBS, IBD will kind of get interchanged. But IBD is definitely different than IBS. Pancreatitis, ulcers, we talk about colon polyps because colon cancer screening is a major part of the lifestyle and the activities of a gastroenterologist. From the liver standpoint, liver disease, hepatology is a major component, especially because of cirrhosis. And can be caused by multiple factors, but the top three: alcohol, fatty liver disease, and also hepatitis C. Gallbladder management, and also not as commonly associated, but things that we still see: hemorrhoidal management, non-surgical, and also post-bariatric surgery management. So we do a lot of endoscopies, we'll do a lot of nutrition disorders, and also some anemia, because depending on what type of bariatric surgery a patient may have. And of note, I just put this when making the slide because sometimes gastroenterologists, especially among other physicians, are just looked as procedure oriented. But as mentioned, we also take care of, the liver. We're liver trained, maybe not liver transplant trained, but we take care of liver, and also we take care of hemorrhoids. So kind of the proctologist, but we also work closely with our colorectal surgeon colleagues. So traditionally, the lifestyle of a gastroenterologist was mostly an outpatient subspecialty. Okay, outpatient subspecialty, usually of internal medicine, but you can also be a pediatric gastroenterologist, which we'll go into a little bit. So, as an outpatient adult gastroenterologist, you are predominantly clinic based. Now, depending what type of community practice that you are in as a gastroenterologist, you may be in a single specialty GI only group. The group that I was in Southern California was a 10-person GI group, and we had 2 or 3 nurse practitioners. Okay. Or you can be in a larger multi-specialty system like a Kaiser or a Sutter, where you have a whole bunch of different doctors in a group. And even though you're a specialist, you're still involved in a major group. So you're not just behaving as a single entity. So there's different politics and different business things that can go in there. As a gastroenterologist, in that traditional thing, you're doing procedures. Now you can do procedures in the hospital for emergencies. You can do outpatient procedures in the hospital. And then you can also do outpatient procedures in a surgical center or an ambulatory surgical center, which is otherwise known as an ASC. Um, in a community practice, which I was before, you are sometimes going to be on call for the hospital in the emergency room, and you get called for emergency consults for emergency procedures. And then in the hospital setting, sometimes you get called for routine GI consultations in the hospital. It just kind of depends on the setting and the community. Now, when I was finishing my training and I started finishing my training and I finished my fellowship more than 20 years ago, there started to be a trend for not just regular internal medicine hospitalists, but GI hospitalists. And I almost stayed on at my position before to help start a GI hospitalist program, but things changed and I decided to move on. But I know these days there are GI hospitalists. Now, in addition to that, there are some hybrids. So similar to a traditional model, sometimes a 10-person GI group like the one I was in before, they'll have one of the GI doctors cover the hospital for the week. So their outpatient load, their outpatient clinic, and their outpatient procedure schedules are on hold for that week, but they take care of the hospital. So it's usually one or two, and then if there's emergency on night, one or the other, like say 9 GI doctors would cover for emergencies and just pass it on to the GI hospitalist partner in that group for the week. Now, if you're in the hospital and you don't have to deal with outpatient management of patients, then you're just based on inpatient consultation and emergencies. And if you're specialty trained with intervention like advanced endoscopy, such as endoscopic ultrasound, ERCP, doing routine, feeding tube peg placements, that's the responsibility of that GI hospitalist for that week per se. So we can go more into that. There's different variations and lifestyle and schedule can vary depending on group. Now, the typical path to a gastroenterology is usually after medical school, 4 years of medical school, you match into a residency. Most gastroenterologists, internal medicine, and there's also pediatric gastroenterologists. So internal medicine, we'll just go with that because that's what I went through. The first year, PGY1 is internship. The second 2 years are junior and senior resident, okay? Internal medicine, PGY2 and 3. Now, typically, at the end of your second year, beginning of your third, you're going to apply for a fellowship, whether it be GI, cardiology, pulmonary, ID, et cetera, rheumatology. Now, similar to medical school, applying to medical school, similar to applying to residency, that's usually in the transition at the beginning of the last year. Once you get into a GI fellowship, which is pretty competitive, and there's a match, the fellowship is about 3 years. Most GI fellowships are 3 years. I was fortunate enough to train in the days where I was able to do ERCP within those 3 years. So when I finished my training, one of the things I liked about getting accepted at USC, I finished at USC, was in the third year, you are basically the ERCP fellow. So it was kind of combined. These days, of course, they stretched it out. They want to add research years. So now most GI fellowships, 3-year GI fellowships, they may have you may get some exposure to ERCP, but you're actually hands-on doing cases may be limited because now they push it to the advanced fellow, which is the next one, which is some places now they will just offer 1 to 2 year advanced endoscopy fellowships, and you will be trained just to do endoscopic ultrasound, just to advanced ERCP. There are other fellowships after the routine 3-year GI fellowship. Well, my co-fellow, when I finished at USC, she was interested in hepatitis C. She was interested in liver. So she was, call me crazy, but she was crazy enough to do liver transplant. So she went on and did another 2 years of liver transplant to be liver transplant fellowship trained and board certified. So medicine, just like anything else, if you really want to get super specialized, you can, but you don't necessarily have to. And as I mentioned here at the bottom of the slide here, just like a match for internship residency, there's a match for fellowship as well. I don't believe there's a match for advanced fellowship, but at least for advanced biliary, there might be a match, but liver transplant, I don't believe there is a match for it. But I mean, you can keep on adding up your PGY 1, 2, 3, 4, 5, 6, and then plus, plus, plus if you desire so. But a lot of those who end up going that track, you will usually end up staying in academics, which is perfectly okay if that's their desire. Now, why do I like GI? After many years, decades and decades, I believe, of course, in my opinion, GI is the most practical specialty in all of medicine. Now, not just internal medicine, I would say medicine in general. Now, I'm going to list some things here that I put on the slide, and I can go further into it if needed. So GI, it's the broadest mix. You deal with a diverse population, not just of gender, male and female. You also deal with age. Like I mentioned, you can be a pediatric gastroenterologist, but you can also influence a whole bunch of different ethnicities. So, colon cancer screening is a main premise of what we do as gastroenterologists. So most ethnicities, minority ethnicities, they have a higher risk of certain diseases. Unfortunately, colon cancer is one of them. So you get to work with, underrepresented minority populations. So I like that. Pediatrics, inflammatory bowel disease in particular, when a young patient has ulcerative colitis, Crohn's disease diagnosed by their pediatrician, they eventually become adults and they have to hand it off to an adult gastroenterologist. So that's a specific population that we take care of. And the other spectrum, when patients become elderly in the geriatric population, we take care of those patients as well. So to me, like there's a full spectrum of population of patients that a GI doctor can take care of. Number two, I think and I feel that being a gastroenterologist is the most flexible. Now, what I mean by flexible is you can kind of cater to see how your lifestyle and schedule will be. In other words, even though it's an office-based specialty, and because we do a lot of procedures, your day can be different. It's not always going to be the same. So I think on the next slide, when we get to the next slide, I'll kind of elaborate more on what a schedule could be. This was my old schedule when I was in Southern California of what I used to do. But the other thing about being flexible, besides procedures, is that if you go along in time, you get seniority and you kind of know exactly what you want. You don't have to be quote unquote full time, in other words. So there's opportunities to explore other things. I mean, I have a entrepreneurial type mentality. I like teaching, as Kartik kind of knows. I've also in my history, there's also the opportunity to look at non-clinical careers, not just take care of patients. In other words, I've interviewed to be an assistant medical director. I've interviewed for medical device. I've interviewed for pharmaceutical, because especially IBD medications there's a lot of pharmaceutical openings for clinicians who want to be speakers. Okay, so you can kind of do that part-time while you're still in practice, or you can totally go on one of their speaker bureaus and get trained and travel. Okay, so that was something I did consider, but for reasons at the time, I chose not to. Okay, and the next thing, which I think is extremely fulfilling, is the collegiality in being a gastroenterologist is, I think, unlike any other, because we're internal medicine doctors, because we are proceduralists, because we have a certain mentality to be experts in our field, and we can get that immediate satisfaction and immediate feedback by doing a procedure, that allows us to work with so many different type of colleagues. We refer back to our primary doctors. When we do CT scans, we'll talk to the radiologist. When we find a cancer, we find a colon cancer, we find a pancreatic cancer, we're in touch with our oncology colleagues. When everyone has chest pain that's non-cardiac, we're still communicating with our cardiologist. Pulmonary, infectious disease, rheumatology, we interact with all our colleagues on different levels, and I find that very fulfilling. We obviously work with our surgeons. So when the esophagus has dysmotility, or we work with bariatric surgeons, they ask us, hey, Eugene, I need to do a scope because I think there may be an anastomotic ulcer. So we'll talk to the radiologist, do an upper GI, Then we'll talk to the surgeon who did the bariatric surgery. I'll send them the pictures from my endoscopy, et cetera, et cetera. So there's a lot of collegiality. Obviously, colon cancer, we'll talk to our colorectal surgeons. When we see a liver mass or we have a biliary obstruction that I did the ERCP and I put the stent in or I took brushings from it, I'll talk to my biliary surgeon about it. Okay. And general surgeons, diverticulitis, appendicitis, routine things. They need to have cholecystitis. I'm talking to a lot of different things. That's what I particularly enjoy. Mid-levels, we talk about physician assistants, we talk about mid-levels. Because the shortage of physicians in general is out there to help meet that gap, mid-levels are going to be, fulfilling that gap. So as a gastroenterologist or any attending, you are in a supervisory role. And if you're like me, you like to teach, you like to explain, having mid-levels is a nice blend of they get to work with the same patients, but they also are your right hand to help deliver the messages and also the care to patients while I'm not around. And nutritionists and pharmacists we work with very closely as well. So this slide is an example. Now there are some variation, but I just wanted to put something out there just to give those looking at it an idea of what some gastroenterology schedules could look like. So Monday, Wednesday, Friday, we usually like to do procedures in the morning. Why? Because patients don't want to be waiting and starving all day after they've prepped to do their procedures late in the afternoon. But sometimes we'd have to do procedures in the afternoon. So on certain days, usually in the mornings, we'll do our procedures. Now, if you look on the Wednesday one, sometimes that endoscopy will also be done at the surgical center, okay? Other times on the weekend, if I was on call on the weekend, I like my procedures to be done on Monday because I'm going to be at the hospital anyway, okay? So on Monday and Friday are typically very common, although hard to get endoscopy block days, especially if you're a junior partner, you're not a senior partner in your GI group. The other days you can say are kind of clinic-based. Now in clinic, you'll see patients, some colon cancer screening, the full gamut of GI diagnosis you're going to see. But I will tell you, probably about 50 to 75% of your clinic patients are going to require some sort of procedure, if not right away, but at some point in their regimen, because they're getting referred to you because they have reflux disease, they have dysphagia, they have rectal bleeding, they have diarrhea, they have weight loss, they have iron deficiency anemia. There's indications among all those to get a procedure. It's just a matter of, are you going to schedule it right away, or are you going to have to do some other test before doing that, before you do the procedure? So when you look on the left side there, our procedures roughly about 60 to 70% of the time, but we also have to see patients, okay? So when you're in the office, you're seeing patients. If it's not going to get a procedure, most likely it's probably a liver issue, a hepatology issue. So we're seeing patients who have fatty liver disease, patients who have hepatitis C, patients who need to be referred potentially for liver transplant. So this schedule is a rough schedule. You'll also see mixed in this schedule is not just the procedures and the clinic. And I've tried to put some wiggle room in there because when you're in the hospital, you'll find that one of your colleagues will say, hey, can you see this patient? I have this patient. And then you'll say, of course. Okay, because especially if you're in private practice, you rarely turn down a consult, okay? Especially if you're young and you're starting up a practice. So that's the way my mentality has always been. And the last thing on that block on the Thursday afternoon, depending on the hospital, because ERCP, you need radiology suite, you need a radiology X-ray to do the biliary intervention. A lot of times in a lot of places, that will get pushed to low priority, even though the patient's high priority, because the hospital is managing their radiology suite. So they have a lot of inpatients and outpatients using the same radiology suite. But for me, in my schedule, I would also often get like a late afternoon at the end of the week. And I prefer Thursday because if there's a complication, I know they're going to be in the hospital on Friday and I'm still going to be there on Friday. It's not going to be on call. So there's a little strategy involved in scheduling, to be honest with you, but this is just an example. What I like about GI, these last two things, there's a certain amount of gratification in actually just doing things. Okay. Now, a common criticism or a common kind of humor about GI doctors is that we're just technicians. Now, I don't mind that. I don't take that as a negative, to be honest with you, because if I'm special, I'm specifically trained multiple years to do a particular procedure and a technique, then I know that's my job. I don't take that. I don't get offended by that. Okay. So there's immediate gratification in doing something based on the skills that I did with my hands in the scope. You remove a cancerous polyp, you will get familiar with knowing what a cancer looks like. If you know there's a polyp that has a cancer, and then I snare it and I remove the polyp with the cancer in it, and then I always ink it. This is technical. I will ink it just in case I need to go back, or if the cancer has spread into the stalk, then the surgeon knows where to go. And so I'm already anticipating what can happen, and you're going to do something positive for the patient. Other things that we do, we stop ulcers, bleeding. I can remove a gallstone if it's obstructed that's causing their acute pancreatitis. I can place a feeding tube into the stomach for someone who has dysphagia, or ENT cases. They are going to get radiation to their neck and they're not going to be able to swallow for another 5 or 6 weeks. They will ask us to put a feeding tube into the stomach ahead of time. We get called for people who swallow weird things. There's a big psych population out there. And when in my fellowship, we took out a whole bunch of things from the esophagus that get stuck in there. People swallow razor blades, they swallow toothbrushes, they swallow glass items, they swallowed a bag of cocaine, heroin. I almost had to take out. Okay. This is all during training, but there's a certain way to do things. We treat patients with overdose, alcohol, Tylenol overdose when you're a liver transplant center. We treat patients with viral hepatitis, acute hepatitis from hepatitis B or C. There's things that you can do. I like educating. So we educate patients on a routine basis in the clinic about routine things that they complain about. Okay, so there's some gratification in there. Specifically, there are needs that we are asked to fill. Colon cancer screening by doing colonoscopies. We do esophageal cancer screening. Esophageal adenocarcinoma is also increasing. So endoscopy is very important. We remove stones by ERCP. We treat bileaks. We treat pancreatitis. And as mentioned before, inflammatory bowel disease is a common thing from pediatric going to adults. And the last thing, there's so much education, not just the patients, but we educate students, house staff, other attendings, and the patients as well as their families. So those are the things that I really enjoy. And that's about it. So I didn't do this. I didn't have my kids come with me. At least if I did have them, I didn't have them come with me to do a colonoscopy. But it is a nice show and tell, because my son used to say, "Dad, all you do is watch video games all day." I'm like, "Hey, my video game skills helped when I was a kid." So yeah, we do. You have to be good hand-eye coordination. So I would often tease in my younger days, when I was athletic and had decent hand-eye coordination, you can actually make a living by using some of those same skills. So thank you for your attention, guys. I think if you click one more, Kartik, yeah, there's my contact information. So if anyone has any questions, wants to get in touch, discuss not just about GI, but anything career-wise, I'd be happy to meet with you one-on-one and go from there. So thank you very much.
Yeah. Quick questions, Dr. P.
Yes.
For liver transplant, like super subspecialty, that's not the actual transplant itself, right? It's the taking care of the transplant.
Yeah, it's non-surgical.
It's okay.
So because when I was fortunate enough when I was at USC, I was very fortunate at the time because I was able to do my ERCP training within my 3 years, and I was able to get exposed to liver transplant training.
Mhm.
So back in those days when it was status 2A, before they had the whole MELD score, patients were in the hospital waiting to be listed, okay, because they were so sick.
Mhm.
So it was a brutal time. I rounded on 40 patients every day, plus took call,
Wow.
plus had to spot present. I think I mentioned it when you were with me before, Kartik. We used to spot present. When you're the fellow, you have to spot present on the patients you admitted last night
Yeah.
in liver transplant rounds the next day in front of the liver transplant surgeons, the fellow, et cetera, et cetera. So If you want to talk about stress and being fatigued, sometimes you're just so tired you can't be stressed. Hopefully you don't experience that too much, but you'll find you're so tired that you can't be stressed. You're just like whatever.
Yeah. Okay. Okay. Thank you. Um, where do you see like GI within like let's say, our time period within the next 5, 6, 10 years? Do you see GI still being one of the top specialties?
Um, Top specialty meaning being in demand and being very selective.
Yeah, because it's like one of the most competitive, also the most salary, like for people who get into it. Everything seems to be the top.
Yeah. I would say once uh, I tell students who are finally get understand how awesome, quote unquote, how awesome GI is. I go, you know what? Once you figure out the secret is out.
Hmm.
Um, because it was super competitive and selective back then.
Hmm.
Um, but then they had to institute the match.
Hmm.
I may have mentioned it to you before, Kartik. I was my top two choices in specialty was going to be a medical subspecialty or a surgical subspecialty back in medical school.
Hmm.
But then, my father's an ear, nose, and throat surgeon. My mother was anesthesia. But I did basic research in undergrad, but it was fine, but didn't really stimulate. Not until I did research in GI during my junior year in college, I'm like, oh, this is kind of cool. And once I was during residency, I figured out how competitive it was.
Hmm.
And I really like cardiology, to be honest with you.
Hmm.
But after my as a junior resident on CCU call,
Hmm.
getting paid for chest pain just kind of drove me nuts. Okay. But of course, you're going to be a cardiologist, so you're not going to get away from that. And I also self-evaluated and I said, I'm very techy. I'm very technical with my hands. And I looked ahead and I said, if I was going to be a cardiologist, I probably would have been an interventional cardiologist, which
Hmm.
would have been 3 years of general cardiology plus another maybe 2 years. And then, because heart disease is the number one killer in this country, that lifestyle and being that close to the hospital is something that I didn't want to pursue. I wanted a balance. So then I said, well, where can I get my technical high, technical satisfaction, but I don't have to be in the ER in 60 minutes? GI. Because most GI emergencies, you have some time. And you don't have a day necessarily, but you have some time. So if someone's exsanguinating, frank hematemesis, hematochezia, the first thing I'm going to ask for, any GI guy is going to say, okay, what's their H&H? Get them to a monitored bed,
Yeah.
and that's going to, thaw two bags, et cetera, et cetera. That's going to give you about 2 to 3 hours, depending on how bad it is. Okay. So with that lifestyle and with the skills that I have, GI kind of fit the bill. So
Got
I think it's just, like I said, I think the secret is no longer a secret. I mean, of course, if you have people like me, giving it the thumbs up for every time someone is interested, we need great doctors. So if you're interested in GI, I'm gonna support that no matter what.
Okay. Nice, nice. Thank you. One last question for me is with the future technology, everything's changing. What specifically is going to be changed within GI? Do you think like colonoscopies are going to be like AI controlled, or what do you see in the future?
Well, during my time, if you remember virtual colonoscopy, virtual colonoscopy was a big thing about 10 to 15 years ago.
Mhm.
And, there was certain CT software, the radiologists were going to make a killing, okay?
Mhm.
But the issue with that was the software was decent, but if they found something, they're going to have to get a
Colonoscopy.
colonoscopy, right? Done by one of us, right? And when you do a virtual colonoscopy, the rate determining step that patients don't like is the prep. So you're going to need to take a prep to do the virtual colonoscopy, and you're going to take to have a real prep to do a colonoscopy. So if you're going to have to do it, why not do everything at once?
Mhm.
And if we do see a polyp or we do see something, we can be therapeutic as well as diagnostic during the colonoscopy.
Mm-hmm.
Now, I will tell you, in Europe, there are self-propelled little robot
Mm-hmm.
um, devices that now self-propel into the colon. Okay, it's almost like Da Vinci for the urologist, so they can kind of control it. Okay, so does the gastroenterologist or the technician have to be in the other end of the scope? No, it may be someone who is better at video games.
Okay.
Okay, so in Europe, there's self-propelled scopes. So that takes the human element out of it. Okay, so whether we call it not necessarily machine learning, but machine driven, I think that is how colonoscopies are going to be, or these cancer is going to go. You heard of Cologuard, you heard us too. I mean, those test for blood or they test for DNA. The thing that's going to change is when there's going to be DNA sampling that's going to identify colon cancer. That I think is the next rate determining step that's just going to um, maybe not put a dent because there's not enough endoscopists to do colonoscopies anyway, but there's going to be more selective colonoscopies, I think, in the future and put risk stratify patients based on their stool DNA, I think is what's going to happen at some point. But even with that being said, because colon cancer screening now dropped from age 50 down to 45, and people are not necessarily getting it done at age 45, so they're showing up more delayed. And unfortunately, they show up more delayed, they're showing up finding more things. So I'm not sure exactly how that's going to play out, but I feel there's still going to be a need for gastroenterologists to do some sort of procedures, if not the interventional procedures.
Got it. Okay. Yeah, thank you for that. We'll call it there. Thank you, Dr.
Oh,
Pantangco, for
oh,
giving
you're welcome, guys. Anytime.